So shifting gears, one of your other lectures, this is interesting to me. So a lot of people have problems with pediatric patients in general, messing up the workflow of their office. But your lecture is even more specialized than this. You're talking about evaluation of special needs patients like autistic patients. It's something that I think a lot of people are uncomfortable with. So maybe you could just talk to us a little bit about what you're doing and how you do it.
Peds is a scary topic in general for a lot of people, anywhere from just, the idea of having to deal with a snotty crying child to, not being sure. It's a reality. They do bite. They do pull hair sometimes. I've had chunks of hair being pulled out of my head.
Wow.
I remember that. There was an intern. Yeah. I had a child with special needs, and the aide walked out of the room, and I was trying to do, what was I doing? I think I was trying to do O-scope, and everything was going fine, but I guess I just got a little too close, and so I got, he grabbed a chunk of my hair, and you can't start, pulling and screaming, because the more frustrated you get or aggravated you get, they get more scared, because they're not doing it out of malice. So I had to kind of just stand there with him trying to pull out a huge chunk of my hair all alone in the room.
That's rough.
Eventually everything was fine, but, just make sure that you're not, the aide doesn't leave the room when you're trying to get close to the patient. That was a lesson learned for me. But, overall, children in general are great, and we're able to do eye exams on totally nonverbal patients altogether. We start doing eye exams on 6-month-olds. So there are a lot of objective tests out there that we can do to get a lot of information both on their visual function, on their ocular health, on their accommodative ocular motor, binocularity system, their refractive state. So we're able to do a pretty comprehensive without the patient ever saying a single word to us. And I think that that's something that people kind of have to go over and get over just by educating themselves and taking CE courses and doing wet labs with kids. Like I've run several wet labs in the past couple of years where I would bring my kids in as guinea pigs or have other kids, being brought in. And we've had people, the baby crawling away and someone on the floor following them with a retinoscope trying to get a ret on them. You have to kind of go with the flow. And there's also auxiliary equipment that you need to purchase and have in the office so that you can use it on these kids, anywhere from visual acuity charts to just $1.99 store toys that make noise, that don't make noise, depending on what you really need. But in terms of the special needs population, it's so much more important, especially for that population, for us to be performing comprehensive eye exams on them, as well as informing the parents and the pediatricians. I prefer starting with the OBGYNs, actually, instead of dealing with the pediatricians, because I feel like we can get through to the OBGYNs a little bit sooner. So all of the OBGYNs in my area. I think it's I don't know. I can't put words in other people's mouths, but probably it's a combination of their education, their MDs, so they will refer to an MD, but it's also a habit, I guess. That's just what they've been doing, and that's what they were taught to do, so that's what they do. But OBGYNs, they don't deal with that whatsoever. So when you come in and you talk to them, they're much more open-minded.
I have a more cynical explanation. You're not going to like this, but I'll have a cynical explanation, having worked with OB-GYNs and doing that. The second the child is born, they want nothing to do with it. It was hilarious. Being in labor and delivery, literally, as they're farmed out immediately to the pediatrician. Like the mom's in one place, the kid goes to the other place, and that's it.
That is.
Yeah, so you're saying the mom is the patient.
True.
Yeah. And so, the OB-GYN wants to be useful to the child, I'm sure, but they don't want to actually have to think about it too hard.
Deal with it. Yeah, exactly. It's like it's alive. That's it.
Yeah, exactly.
You can take care
That's
of it
right.
now.
We take the win, but move on. Right.
Right. But OBGYNs, I have to say, they're much more willing to put up infancy posters. If you're part of infancy, they will send you free posters and things, and they're much more willing to put up posters for new moms, little cards for them to take. They're much more receptive to it. So I prefer to start there just because that's where I've gotten more receptive a more receptive audience.
That's a good takeaway piece of advice there is if you want to get started with working with kids, talk to OBGYNs instead of pediatricians, at least starting out. That's a good piece of advice.
Yeah. Yeah. And then also PTA, like for my kids' school, I asked to do a lecture on pediatric vision and learning for a PTA meeting, and then ever since then they asked me to come back, and then the principal talked to a different school's principal, and so that come in. So
that's great.
That's also a nice foot in the door also to get to the parents, because the parents, again, they want the best for their kids, and a lot of them will come up to me after, hey, I didn't know any of this, coincidentally, Bob has been having problems with reading and blah, blah, blah. And my pediatrician said everything was fine. And, I've had hundreds, if not thousands of these. And so, the PTA meetings are also a great starting point as well.